and I am a consultant medical director for Monteris, which I wanted to disclose. So over the next several minutes, better part of an hour, we're going to go over a few things regarding my personal journey through LITT since the late 2000s. And then also, as Bill alluded to, discuss our journey at the Cleveland Clinic, comparing early experience to late practices. So laser interstitial thermal therapy is not new. It dates back to the 1990s with the German group led by Schwarzmeyer and the American group in Boston led by Yolez, working with a limited technology, bare fiber optics, YAG lasers, diffusing tips only, and no methodology in order to actually monitor what they're doing in terms of the extent of ablation, let alone do it in real time. Now, my first introduction to LITT was actually going to a conference that Yolez had on this technology, and it was kind of a hands-on. We actually got to go to the suites where they were doing this, and it looked like this was a great idea, but it was an idea that was ahead of its time due to limitations of the technology at the time. That said, the basis of this was sound. Heat kills cells, and in the 43 to 55 Celsius range, it does so by apoptosis and necrosis. Now, when you start getting higher than that, you start to get some undesirable factors such as desiccation, vaporization, and carbonization. And it's actually a complex relationship between the actual temperature and the duration to which the tissue has been exposed to that temperature that is described by the so-called Arrhenius equation, where everything is more or less equated to the thermal equivalent of 43 degrees Celsius for X number of minutes. But this does require that in near real time, you're able to have a three-dimensional map of the temperature of the tissue that you're talking about. So the big technological advancement that actually has allowed us to enjoy the modern era of LITT was the invention of MR thermography, which is an accurate way of measuring temperature changes in 3 dimensions over a period of time. And then plugging those numbers into the Arrhenius equation, you're able then to generate maps of predicted kill. Now, the NeuroBlade system itself was invented by a scientist named Mark Torcha from Winnipeg. And his vision was to take LITT to a new level over and above the Boston and German group by using a side-fire laser probe that worked in the neodymium YAG range to be able to remotely manipulate it with robotics. And ultimately, the goal was to have this automated. And then the probe itself would be cooled to prevent char from forming, which limits the penetration of the laser in the tissue, but also helps improve the directionality of the side-fire laser. And then to use the Arrhenius equation and MR thermography to accurately predict the ablation zones. And he produced these 3 different levels of thermal damage. The yellow line, we call the outer boundary, is the equivalent of heating tissue to 43 degrees Celsius for 2 minutes. And everything outside that line is predicted to survive and recover from the heating. The white line is predicted was the equivalent of heating tissue to 43 degrees Celsius for an hour. And everything inside that line is predicted to die. And the blue line, which is the intermediate boundary, is the equivalent of 43 degrees Celsius for 10 minutes. And by different mechanisms, everything is predicted to die. As you're probably well aware, there are 2 FDA-cleared systems for LITT in the central nervous system, the NeuroBlade and the Visualase. Both of these are cooled. The NeuroBlade uses gas, whereas Visualase uses liquid. The laser, they both operate in the near infrared, whereas the NeuroBlade is pulsed, the Visualase is continuous. And although both have diffusing tips, the NeuroBlade is unique in having the side fire. and also positioning the probe in terms of depth and/or rotation is manual with the Visualaise and robotic with the NeuroBlade system. So my introduction to Monteris was back in August of 2006. And I had been invited by Alan Sills and the late John Robertson to give a talk on EGFR inhibitors in glioblastoma at their 5th annual neuro-oncology update in Memphis. And after giving that talk, there was a coffee break, and a white-haired gentleman emerged in the crowd and came up to me and identified himself as Jim Duncan, and that he was on the board of directors of a company called Monteris. It's a new startup company. And he told me briefly what they were trying to do, the same goals that I outlined for Mark Torchia. And he asked me if I thought that this might be something that would be useful in neurosurgical oncology. And I, having been armed, with the information I had from going to the Boston course, I was basically ready immediately to say, yes, I think there's a lot of uses this could have if you can do it well and overcome the technology problems from the 90s. And he said, well, they're working on those, and that he wanted to know if he could call me when they had actually a prototype probe to show me. And so, we shook hands and parted ways. And about a year later, I get this call from Jim Duncan, and he says they've got this prototype probe. Can they bring it out and show it to me? And so he does. And I thought that this was looked like it was a good approach to producing a contemporary cooled laser probe. And from that, the rest is kind of history. I just became a consultant for the company and helped them with their preclinical work, which first was using these lasers in tofu, and then in ex vivo swine brains, and then ultimately in an in vivo canine brain tumor model where they lived for about 21 days after the ablation. And we proved in concept that indeed these TDT lines indeed were accurate and reflected the zones of ablation in the in vivo setting. So I then worked with the company along with the FDA in developing the first in human trial, which was a thermal dose escalation trial, where this was a group of patients who had difficult to access recurrent glioblastoma. And the goal in the first 3 patients was to try and treat as much of the tumor as we could to the yellow TDT line, follow them for 2 weeks, and then have an independent committee review toxicity. And if there were only 1 patient that had toxicity or fewer, we would then move to the blue line, do this again, and then if that was successful, move on to the white line. And this trial was done both at Cleveland Clinic and our friends down the street at University Hospital's Cleveland Medical Center. And over an 11-month period, we enrolled 11 patients and ultimately treated 10. All treated patients had treatment necrosis. The lesions were somewhere between the blue and white TDT lines. Median survival was 316 days. We had 1 patient who survived to 760, but this is glioblastoma, and all 10 ultimately died from disease progression. There were 2 steroid reversible neurologic toxicities and 1 immediate hemiplegia. Now, although not part of the protocol, we did diffusion tensor imaging fiber tracking on all of our patients, since we were doing surgery in parts of the brain we normally didn't, and we thought it was important to be able to map this out. Our friends down the street did not, and in retrospect, it turns out that there was an injury to that patient's corticospinal tract. 1 patient developed neutropenia and 2 others developed DVT. There also were 2 complications that occur outside of that 14-day window. 1 patient had a delayed hemorrhage due to a pseudoaneurysm on a small branch of his middle cerebral artery. Unclear whether that was due to the laser or due to the biopsy, which was part of the protocol. We have not really seen that again, so I suspect it was due to the biopsy. But there was also 1 patient was seeding along the biopsy and therapy tract, and I have seen that from time to time, and I also have a strategy to deal with that. But this is one of the patients from the first in-human study. And if you can see my cursor, this orange line is the predicted kill zone superimposed upon the preoperative MRI scan. And then this row of scans at the bottom are at 24 hours. And you can see that the zone of necrosis very nicely matches the predicted zone. And in fact, these two areas of retained enhancement were predicted again by this kill zone as well. If I had to do this today again, I would have come in on a trajectory like this along the long axis of the tumor. But by virtue of the limitations of the technology we had for placement, we had to come in from above, which limited how much of the tumor we could actually access. As it turns out that we did have two complications in the white line group, and since the blue line does appear to be lethal, the practice now is to use the blue line in terms of therapy. But what we learned from the first in humans trial was that first off, LITT in brain tumors, human brain tumors was feasible, that the TDT lines were truly predictive of ablation. The extent of ablation was best observed at a 1 to 2 day post-ablation scan with a T1 contrast enhanced MRI. Some of the neurologic toxicities were reversible with steroids, and the ablation stops at heat sinks such as the ventricles, sulci, and large vessels. And then finally, the importance of DTI fiber tracking, so important now that you can import these DTI fiber tracks into the MVision software and see their location with respect to what you're ablating at the time. And this paper from my colleague Ali Mohammadi looked at 80 patients and showed that indeed that even small overlap of hyperthermic fields with these fibers is correlated with unfavorable outcomes. Brown in this case being patients who had deficits, green patients who did not. So questions about this part so far?
Which clinical study do you think was critical to the preclinical study was clinical to the FDA study onset?
So I think the 3 weeks of the in vivo dog study was important, but it was really the first in human study that led to the FDA clearance. Does that answer your question?
Yeah, thank you.
All right, so buoyed by the experience in recurrent glioblastoma, we decided to start to try this in upfront newly diagnosed patients. This was a lady from Florida who has this enlarging lesion in her mesial temporal lobe. And we did a biopsy and ablation at the same setting. This is what her ablation looked like at 24 hours, really a very, very nice ablation. She then went on to stoop therapy. This is what her tumor looked like at 3 months, 1 year, and 2 years and 3 months. Truth be told, she never recurred at that site. She actually recurred at a distant site, not along the biopsy tract. And we actually have about 3 patients who had sustained local control who had then recurred remotely at a later time. And this is another one. This is a man in his 40s who had a seizure in the shower. He had this ring-enhancing lesion in the cingulate gyrus immediately below his paracentral lobule. So not the kind of place that you'd be too enthused about operating. So we biopsied and did an ablation at the same time. He had a little bit of a foot drop for a few weeks, but that resolved. He went on to stoop. You can see now 6 years plus of local control. And he recurred elsewhere, laterally in his left frontal lobe in his speech area, and he went on to succumb to that about a year or so later. This is a patient with a recurrent frontal anaplastic astrocytoma. And by virtue of the limitations of the guidance device we had at the time, I just wasn't able to get a good ablation at the very top of this. She then went on to some chemotherapy. You can see that for the first few months, she seemed to have good control with regression of the tumor, but then she actually recurred at that superior area, and she underwent another ablation with good local control but then she recurred on the opposite side of her brain. This is a young woman in her 20s with a biopsy-proven anaplastic astrocytoma. And you can see these two zones of enhancement here and the close proximity of her projection fibers to this. So I kind of wimped out on this and just treated her to the yellow TDT line, and probably was a good thing. And you can see the edge of the ablation here with the retained lighter gray around it. She did not have any neurologic deficits, although did go on to wind up having a shunt placed. She then went on to stoop therapy, and here's what she looks like now 80 months out. And I don't know what this is that we're looking at, but it's not growing. And she's graduated college and is gainfully employed at this point. So really a great story in terms of local control. And for one, she hasn't recurred elsewhere, knock on wood. This is a patient with a cystic thalamic tumor that I initially turned down because I didn't think this was going to work because of the heat sink effect of the cyst. And then I had a meeting with my colleague, Eric Luthart from Barnes Jewish, and he was saying that, oh no, he does cystic tumors all the time. It works just fine because it's not like it's an infinite heat sink like the ventricles, rather the fluid is encased. And so once it warms up, it heats the tissue next to it. So I then went on to do an ablation. He had a very nice ablation and wound up having great local control, although he then recurred along the biopsy tract at about 1 year and went on to have further therapy of that. This is a patient who had a multifocal GBM. You can't see it on the screen, but he had another lesion over here that was excised and treated with radiotherapy. And this area up front was also treated with chemoradiotherapy, but progressed right through it. So with a two trajectory approach, we then ablated that, and he went on to have, good local control for several months, which you wouldn't ordinarily expect in this setting of a butterfly glioma. So what I've learned from the clinical experience since the first human study is that it's possible to get durable control of newly diagnosed high-grade gliomas when followed by stoop therapy. A butterfly glioma ablation is feasible, and there actually is a publication out there suggesting that it's better than not doing it at all. Thalamic tumor ablation is feasible, cystic tumor ablation is feasible, and one of the other important points is that unlike craniotomy, there is no brain shift because the laser probe itself plugs the hole in the dura that keeps the fluid from draining out. A couple other little take-home points. It's very important to make sure that your anesthesiologist keeps the patient's temperature up. The FDA cleared wattage for the NeuroBlade system is 12 watts. And that if you use a 12 watt and you have the patient at 37 degrees, you'll be able to push out to around 14 or 15 millimeters. On the other hand, if the patient is cooled down to 35 degrees, you may be only out to be able to get 11 to 12. Now, there was a period of time where we actually had an investigational pulse setting of 15 watts, and you can see that you can really push it out at a normal body temperature to over 20 millimeters radius, and hopefully some point down the road we'll be able to do that. Also, the basic strategy is you always want to work down the long axis of the tumor if you can. If you have a tumor that kind of looks like this, you want to come down there so you're using the radius of the laser for the side probe along the long trajectory. But large tumors are a problem in terms of coverage because even if you would say use 4 trajectories here, you have all these areas that are left untouched. And you'll see down the road as I show some studies that as the tumor enlarges over about 10 to 12 cubic centimeters, that coverage suffers, as does then control. So here's a paper out of Wake Forest, WashU, and Cleveland Clinic from Cancer Medicine, where we pooled patients, 24 of which had glioblastoma, 10 had grade 3s. Median age was 56, most of them were male. These were all supratentorial, but included 7 thalamic tumors, of which 16 were up front, and the remaining tumors were recurrent or progressive, and the time to recurrence was 29 months in terms of a median. A wide range of tumor volumes, from anywhere from 1 to 50 cc's, And in terms of complications, 5 temporary deficits, 2 were sustained, 1 death from an intracerebral hemorrhage. This is one of my infection patients. This was a 3-trajectory case early on when we had fairly limited technology. This was like a 15-hour case. Little wonder that he got infected, but you can see that he had a really great ablation. And this is what his brain looked like 3 weeks and 7 weeks, where he had a rip-roaring cerebritis. But the good news was we didn't have to remove his bone flap, because all we did was a twist drill hole. And he was treated with antibiotics. And you can see that actually at 4 months, things had settled down. And over 2 years out, he had no evidence of residual or recurrent tumor, which is pretty good for a recurring glioblastoma. And ultimately, he died from an unrelated systemic problem. He never actually had recurred in his brain while alive. The median survival in this group was not reached. The estimated 1-year survival was about 90%. Progression-free survival was about 5 months. And there were 2 favorable prognostic factors that were identified. One was the extent of ablation, as defined here, and also smaller tumors. And the part of the problem about separating these 2 is that the smaller tumors had better coverage and the larger tumors had poorer coverage. But if you look at the favorable coverage group, that there was a statistically significant difference in progression-free survival of nearly 10 versus 5 months in that group, which is pretty much comparable to what you get from a complete surgical resection versus a subtotal resection in these high-grade tumors. I think there's 2 examples here that kind of bring this home in terms of the importance of extent of ablation. You saw this case already. This is a woman who's about the same age with a tumor that's in a similar location in the mesial temporal lobe, both of which underwent biopsy and laser ablation. Here, as you saw, a terrific ablation. Here in this case, no matter what I did and how long I kept my foot on the laser pedal, I could not make the heat move into this medial zone. I had an ablation on the outside, but not inside. And I think probably what happened was that there was a sulcus coming up inferiorly that I was unaware of that was acting as a heat sink to keep this from happening. Well, they both went on to stoop, and as you saw, great control in this woman, and this woman just went on to progress, wound up having craniotomy, died several months later from tumor progression. This guy acted as his own internal control. Our goal was to actually treat both of these in one setting, but we had some technical problems which did not allow us to move on to the second tumor. So we had a great ablation here, no ablation there, and he chose not to go on to have a second ablation, but then just went on to stoop. Well, here he is at 3 months. We see this kind of characteristic eggshell of enhancement in the area that was ablated. And here now he's got a progressive rind of tumor. This is the cerebral blood volume. You don't see any elevated cerebral blood volume for the ablated tumor, whereas you see a lot of elevated blood volume there. And then this is what he looked like 5 months out on Avastin. Again, really nice control here, lack of control there. And he went on to die around 6 or 7 months after the procedure. So again, an internal control showing that extent of ablation is important. And I mentioned before that the extent of ablation appears to be comparable in terms of progression-free survival as extent of resection, and that this was one of the first papers that suggested that size really may matter. This is a more recent paper that was a multi-center retrospective study with Cleveland Clinic, WashU once again, and this time Yale and Duke. So these were contemporary cohorts of newly diagnosed patients who underwent biopsy and stoop, or biopsy, laser ablation, and stoop. At the time these patients were assessed, Cleveland Clinic and WashU were doing ablations for upfront gliomas, high-grade gliomas, but Yale and Duke were not. And so the treatments that they got post biopsy were the same in both groups because they were contemporary, but the only real difference was the laser ablation. And these were propensity matched by age, gender, tumor location, and tumor volume. And we looked at overall survival, progression-free survival, disease-specific overall survival, and disease-specific progression-free survival. And overall, there really wasn't much difference between the 2 groups in terms of recurrence and there was a trend towards fewer deaths in the laser group, but overall survival was about the same. But when we looked at favorable coverage, again, extent of ablation, then the landscape changed. And once again, smaller tumors had a much more favorable extent of ablation, whereas larger tumors, it was much more difficult to get the level of ablation that you would like. And this is reflected in the disease-specific overall survival and the disease-specific progression-free survival, that both were statistically significant in favor of laser ablation. So kind of class 2B evidence that laser ablation is superior to biopsy and stoop alone. So once again, coverage is an independent predictor of all outcomes except maybe overall survival. And it was a safe, statistically superior treatment with stoop compared to biopsy and stoop alone with an adequate extent of ablation. Questions about the glioma experience up to this point? All right, so where are we going with this? Well, Eric Luthart and his group have shown that the blood-brain barrier around the area of ablation stays open for a few to several weeks afterwards, which then opens up some interesting possibilities. One of which is that you could use an alternative chemotherapy in the early post-ablation period that doesn't get into the brain because of the blood-brain barrier. Now that's limited in terms of the amount of time, but nonetheless, you can do that, and he's got a trial going with doxorubicin as the agent. Also, because you have basically a stab wound instead of a craniotomy wound, that you may be able to proceed with early stoop therapy because of minimal wound healing issues. So we have a trial at the Cleveland Clinic where actually they start within a week of the actual biopsy and laser ablation. You know, there's lots of thought regarding what's the impact of laser ablation on the immune response. Are you generating a lot of different cytokines or proteins that may trigger the immune system, or is the fact that you use steroids and these are denatured, will they have no impact? So a lot of interest in the research going on in those areas. You may have noticed that I haven't shown any low-grade tumors or any non-enhancing tumors, and that's because in our experience, the extent of ablation that you get in these non-contrast in tumors is a much smaller volume than you can achieve in contrast enhancing tumors. So perhaps we could come up with some low-grade tumor-specific thermal contrast agent that would facilitate that, something like quantum dots. Also, right now, the technology requires that you have either a diagnostic or intraoperative MRI. There may be some other schemes in order to monitor what's going on in terms of thermography other than MRI down the road. And boy, I'd give my right arm for a program that would tell me exactly how many probes to place and where. So keep that in mind, the people from BME. One of the topics I haven't really touched on is the large tumor, and that is that if you start to have volumes more than about 15 cc's, you really need to think about the environment of the intracranial space. You know, I showed the case where I did the 3 trajectories where the guy got infected. He had a 50 cc tumor, but he also was old with an atrophic brain, and he had a big resection cavity, and he had minimal edema. I had another case of a young woman that we did a recurrent brain metastasis who had a 50 cc tumor, and she had a full brain edema, and she had no resection cavity, and she went on to herniate at about 3 a.m. in the morning. So in these large cases, oftentimes what we do now is we just do turn like a 1-inch craniotomy around the twist drill hole and go down the biopsy or laser probe track, and then do a subtotal resection, a debulking operation, if you will, which is typically very fast because it's avascular after the ablation, and it sucks up pretty nicely. Some people have actually just used a Nico Myriad device down there. That I tried that actually once, and it scared me, so I just turned the craniotomy. Also, I alluded to earlier the issue about seeding. We've seen several cases of this where I did the ablation going from deep to superficial. And what occurred to me is that I'm actually dragging viable tumor cells along the laser probe. So these days, for any type of deep tumor, I do my ablation from superficial to deep, and knock on wood, I have not had any seeding of the biopsy tract or laser probe tract taking that approach. And then lastly, what about surgery in the eloquent cortex, particularly speech? Well, we do all our cases under general, so you really can't do brain mapping. As some people actually do these procedures awake, we have not. But I think what may make this feasible down the road is resting state fMRI, unlike the fMRI that we use now, the bold fMRI. So stay tuned. I think that's going to be a significant advance. Any other questions about gliomas for now?
Checking the list, and it does not look like there are any questions. So please continue.
Okay, so I'm going to shift gears to brain metastases, and you're all familiar with the options, but where LITT fits in is something of a question. And really the workhorse for most brain mets is stereotactic radiosurgery. And you've got a number of different outcomes ranging from no effect to temporary control, durable control, radiation necrosis, or a combination of recurrent tumor and radiation necrosis. Now, most centers use some variant of the RTOG 9005 dosing scheme of 24, 18, or 15 gray, depending upon the size of the tumor. But as it turns out, dose matters, as you know, it should be no surprise. And then you get much better durable control at 24 gray than you do at 18, 15 gray. And in fact, if you live long enough, you're more likely to have the tumor recur than not if all you give is 18 or 15 gray. On the other hand, if you give more than that, then you start to get the risk of radiation necrosis, and you know, it's a dose-volume relationship that was identified back in the 60s by Gelberg. So the approach that we've taken to this is doing two-stage radiosurgery, where the first day they get the standard RTOG dose of 18 or 15 gray for the larger tumors. Then we come back in a month and then give them a total of 30 gray, so they get 12 if they had 18, they get 15 if they had 15. And you can see here that oftentimes the volume actually reduces very nicely at the time of the second treatment. So you're actually irradiating a lot less brain with that 12 or 15 gray than you would have if you had given it all at once as 30 gray. And we have a durable response. Lily Angelov is the neurosurgeon in our group who's been leading that effort. Well, what about though when radiosurgery fails and you have recurrent tumor? Well, this is one of the early papers from Alex Carpentier using the Visualase device, where he identified once again that extent of ablation matters. In the 3 tumors that had partial coverage, 2 of the 3 recurred at 3 months and 1 patient died. On the other hand, for those that had complete tumor coverage, none of those tumors recurred at a 3-month period. And there's a number of other papers that indicate the same result in terms of the early experience using LITT for recurrent brain metastases after stereotactic radiosurgery. Here's an illustration from Clark Chen, patient with metastatic breast CA, failed radiosurgery. This is what it looked like at 1 month after ablation, which looks kind of scary, but then it involuted at 3 months and had durable control. We all know what radio-resistant brain metastases are in terms of fractionated radiotherapy, renal cell melanoma being the 2 prototypical ones. But there's an emerging literature that suggests that there may indeed be radiosurgery-resistant histologies, triple-negative breast, colon, BRAF wild-type melanoma. And I have to tell you, I cringe every time I see a patient with a colon tumor, because I know that the likelihood of getting durable control with radiosurgery is actually pretty low. And the case has been made by Clark Chen and others that perhaps in this population, we should be doing laser ablation followed by fractionated radiosurgery rather than single session radiosurgery alone. And I'm seriously thinking about putting together an IRB to do this, just that, in the colon group. Now, the flip side of recurrent tumor after radiation, radiosurgery, is causing local brain damage and adverse radiation effect of radiation necrosis. And to my knowledge, we had the first report in the literature of using laser ablation for this particular problem. This is a guy in his 70s, a diabetic from Florida, who had a 5mm lung met treated with LINAC radiosurgery about a year earlier. And he then developed steroid-dependent radiation necrosis, where he'd become hemiparetic and aphasic if they tried to get him off the steroids. And metabolic and perfusion, metabolic studies such as FDG PET and perfusion imaging indicated that this was almost certainly radiation necrosis. So we biopsied this and did a laser ablation based on some anecdotal reports out of Europe. And this is what his without and with scan looked like at 24 hours. So now he's got this thin eggshell of enhancement where he had this rind of enhancement. And more importantly, this is what it looked like 3 months and 6 months later, where you can see that there's been rather rapid regression of this mass over time. But even more importantly is what happened to his edema. Because here he is at the time of ablation, just before ablation, on 16 milligrams of dexamethasone a day. And here he is 5 weeks later off dexamethasone, and the edema has almost completely resolved. So a lot of people have a hard time wrapping their heads around why is it that coagulation necrosis is a treatment for radiation necrosis. And the reason for this is that radiation necrosis is in fact a misnomer. Radiation necrosis is a living vasculopathy that's self-propagating. And what we do is we kill the zone of vasculopathy and turn it into coagulation necrosis, which then no longer generates edema. This has been shown to be effective in a prospective trial, the laser trial that was led by Veronica Chang. In this particular study, which was a multi-center study, it was shown that if you had a complete ablation of radiation necrosis, that you had durable control and you reduced steroid dose. If, on the other hand, you had complete ablation of biopsy-proven recurrent tumor, you had about a 70–75% durable control rate. And for that reason, a number of centers, including ours, now do 5-session radiosurgery in addition to that when we have biopsy-proven tumors. So we always do a biopsy when we do a radiosurgery failure because it changes how we actually approach those patients afterwards. So when do you use LITT for brain metastases? Well, for any kind of radiosurgery failure, either recurrent progressive tumor or radiation necrosis. I still think the question's out there, or whether or not you should use it for radio-resistant histologies. As I said, I would do it under an IRB. And you know, larger lesions are less likely to respond to radiosurgery from a single session, but our experience has been that we have really excellent durable control from 2-stage, so probably not a need to do laser ablation in those particular cases. So now this is a very recent study that was published in World Neurosurgeon that really looks about how our practice at Cleveland Clinic has changed over the last several years. It was a retrospective chart review from 2011 to 2018, and we excluded the few cases that were aborted. We classified them into 2 different time periods, early from 2011 to 2014, and then more recent from 2015 to 2018. And we collected the usual demographics: tumor size, location, operative time, and surgical morbidity as well. And then statistical analysis aiming towards overall survival and progression-free survival versus tumor size, and overall survival, progression-free survival versus tumor location. The vast majority of what we did was high-grade gliomas. Coming in second was radiation necrosis, then some low-grade tumors, and then metastases. So the patient demographics were very similar except for age. And initially, we were choosing younger, healthier patients, and over time, we expanded this to some to older patients who may be indeed somewhat more frail. The operative time was significantly reduced in the recent group compared to the older group, and also the significantly decreased the number of trajectories that we use, where we did up to 4 in the past, and now the vast majority have a single trajectory, and some have 2. If you look at operative time, this is a plot over time, and you can see that there's been more or less a steady decrease. There was a bit of an inflection point when the new generation of the NeuroBlade system was introduced in 2013. There also were decreased complications and improved outcomes. The decrease in permanent deficits significantly was less in the newer group. But there was no statistically significant difference in those who had temporary deficits between the 2 periods. Also, large hemorrhages were much less frequent in the more recent group, as was 30-day mortality. But that was a trend, not statistically significant. There also was a trend for lower infection rates and fewer patients with prolonged hospital stay. But again, this may be a sample size problem as opposed to that there really wasn't a difference. And you can see our case mix has really changed over time. That the dark blue is radiation necrosis. And so that has become a much larger part of our practice than it was in the first few years. High-grade gliomas has decreased as a fraction, and in fact, you can see that like in 2018, we didn't even do a low-grade glioma. So again, LITT is being used more frequently in the radiosurgery failure case than it was early on.
Hi, Dr. Barnett. So my question is, have you identified any, how can I say, thermal ablation sensitive tumors in a parallel to radiation sensitive tumors? Are some tumors doing better with LITT? Thank you.
To answer that question, I think it comes down to the thermal conductivity of these tumors. Many people don't realize that the laser only penetrates a few millimeters, and that the rest of the ablation is due to conduction. And there's a lot of things that affect that. There's the actual conductive heat properties of the tissue itself. There's blood flow, which can act as a sink. And I personally believe that the presence of gadolinium may facilitate the flow. So, you know, in terms of resistant tumors, my impression is that non-enhancing low-grade tumors tend to be LITT resistant, just because it doesn't propagate, and that you get better coverage for low-flow things like radiation necrosis. You have a larger extent of ablation that's possible than for tumors that have higher flow, such as high-grade gliomas and recurrent metastases. Does that answer your question?
Yes, thank you. That's really helpful. Thanks.
But I want to bring home the point that anything in the blue line is dead, regardless of what kind of tumor it is. It's just, you know, that's non-specific. But it's just a matter of how big a radius that blue line is from your laser probe. So going back to this, if you have a poor preoperative KPS, then you're more likely to have a permanent deficit, and your overall survival is expected to be less. All right, so and I think some of the changes that we've seen over time have stemmed from the improvement in device technology and also more experience in surgical planning that reduces the operative time and the number of trajectories. That, as I showed earlier, that it really is important to import a fiber tracking in cases where you think you're going to be near critical fiber bundles, and to keep those the yellow TDT line out of those bundles. And there's been a trend, but not significant, towards utilizing LITT in smaller tumors, more utilization in radiosurgery failures, and a decrease in infection, massive hemorrhage, and mortality. And then lastly, I wanted to just talk about Lantern, which is a prospective multi-center real-world outcomes registry. And all patients undergoing LITT are eligible to this, up to 1,000 patients at 50 sites and 5-year follow-up. And study objectives really are to look at safety of LITT, the indications for neuroblate, and procedural outcomes, as well as quality of life. Right now, there's 24 sites and over 600 patients have been enrolled. And you can see that already 3 publications are out there, the most recent being on laser ablation of using the neuroblade system in terms of 12-month outcome and quality of life after brain tumor ablation. So look to the future for more publications, and also I believe that Monteris is going to have a webinar in the not too distant future looking specifically at the Lantern registry. So to kind of sum up, where does LITT fit into my practice? Well, it's for suitably sized, and again, you're talking here about probably 12 cc's or less for the most part, 12 to 15, recurrent high-grade glioma, known or suspected newly diagnosed deep high-grade glioma, deep enhancing tumors of any type, minimally invasive patient preference, very small non-enhancing tumors, or you might do what WashU does, which actually they stage those. And they might do part of the tumor one day, have them come back in a month, and then do another part, and have them come back in another month and do a third part. We haven't done that yet, but that's out there. Failed radiosurgery, we always get a biopsy because it changes what we do. And then the question remains, how about deep radiosurgery resistant metastases? Again, I think that there's not enough evidence to make this part of standard practice, at least from my view, but the kind of thing that we might start investigating. So I spent the first probably 20, 30 years of my career trying to disprove the notion that back when I trained that the only good craniotomy was a big craniotomy, and that minimal access craniotomies using navigation was just fine. But I think the new generation of neurosurgeons will find that probably this is even too big, and now we'll be using the twister holes with the mini bolt to address many of these tumors. And I do want to acknowledge a number of my colleagues. There's probably a lot more of these than on this slide, but they come from multiple institutions and from multiple cities. And on behalf of our team at the Rosella Burkhardt Brain Tumor and Neuro-Oncology Center at the Cleveland Clinic, I thank you for your attention. And again, I'm open to any questions you may have.
What is your opinion on steroid versus non-steroid based anti-inflammatory drugs post-LITT management?
Well, I think you need them, particularly if you've got a relatively big tumor. One of the things I didn't talk about is that virtually everybody who's looked at it sees that the tumor volume actually increases in the immediate LITT period for at least a week or two. Now, whether that's going to be clinically significant depends upon where it is and perhaps how much edema you have in the first place. But you know, I'm personally pretty liberal in the first few days, and then depending upon the big picture, I try and get them off within about 10 days to 2 weeks. Sometimes you can't get them off that fast. I know there are some people who try and get them off even faster, and that certainly there's some concern that this may minimize any immune effects, immunologic effects that the ablation might stir up. But again, whether or not that's real, I think is unproven. What's your alternative? Well, your alternative, would be non-steroidals, which doesn't work very well, or Avastin, and I'm kind of not thrilled about using Avastin in the immediate post-op period. All right, well, thank you all for attending this on a Wednesday afternoon or evening, depending upon what time zone you're in.